The combinations can be different, as you can see out here. We saw a couple of slides of central retinal vein occlusion with ciliary artery occlusion. Can be a combined CRAO and CRVO. Most of my talk will be dealing with this. A branch retinal artery occlusion with the CRVO, BRAO and BRVO, combined BRVO and hemispherical retinal vein occlusion. These are all the combinations which can occur. So central retinal vein occlusion with ciliary retinal artery occlusion is probably the most common disorder which we will see. Why does this occur? Because the perfusion pressure of the ciliary retinal artery is less than that of the central retinal artery, nearly about 20 to 30 millimeters of mercury lesser than that of the central retinal artery. So that predisposes it to an occlusion. In addition, there is no auto-regulation in the ciliary artery. But in the central retinal artery, if the blood pressure goes down, perfusion pressure goes down, the blood pressure shoots up to increase the amount of blood flow. But that auto-regulation is not there in the ciliary retinal artery because it's connected to the choroidal circulation. The central retinal vein occlusion also increases the intraluminal pressure in the retinal capillaries. There is a backflow against the ciliary retinal artery. That is why it occludes faster. In addition, there is disc edema in the central retinal vein occlusion. This disc edema also compresses on the ciliary retinal artery, resulting in an increased occurrence of central retinal vein occlusion with ciliary retinal artery occlusion. Risk factors are pretty much the same as that of central retinal vein occlusion. We need to consider these, which are something which can be common in younger population. So we need to ask for the use of oral contraceptive pills and also hormonal treatment. Many of our younger population have infertility problems and they are on hormonal treatment. So it may be associated with the prolonged irregular retinal arterial filling. If you were to do a fluorescent angiogram, this has been found in one of the trials. And some of these patients, particularly young patients, can be treated with oral steroids, resulting in good visual results. There is no role of paracentesis in this combination of ciliary retinal artery occlusion with central retinal vein occlusion because the pathogenesis is different. The occlusion, backflow in the capillary bed cannot be reversed by doing a paracentesis. So there is no role for paracentesis. Most of these patients can be observed. And as I mentioned, you can give a short course of systemic steroids. But we can treat them pretty much like a central retinal vein occlusion. If there is an edema, like cystoid spaces decrease in vision, we can use anti-VEGF agents or steroids. So this is one such patient with the central retinal vein occlusion and the ciliary retinal artery occlusion, as can be seen by the edema or like the retinal whitening just involving along the branch of the ciliary retinal artery. And this is about 1 week later, the hemorrhages and the retinal whitening are decreasing. As about 2 weeks later, the whitening is nearly gone. Though what we see is something which is good. The patient always complains of an inferior sectorial relative scotoma. That is something the patient will continue to complain. It may not come back to normal. We have to assure the patient it will come back nearly to normal levels. About a month later, the CRVO is also gone. This patient was treated with a short course of systemic steroids. Combined CRAO and CRVO, how is this different from a CRAO or a CRVO? It's a much more serious disease in contrast to CRVO. There are very, very serious life-threatening diseases associated with this combination of CRAO and CRVO. The causes can be infective, as in the case of orbital cellulitis and cavernous sinus thrombosis, and there is something which can commonly occur in patients with fungal mucormycosis of the orbit. So this is a kind of an ischemic necrosis which can give rise to both combination of CRAO and CRVO. Infective retinitis, as in a CMV, and infective endocarditis can also cause combined CRAO-CRVO. Systemic malignancies, particularly meningeal carcinomatosis and optic nerve metastasis lymphoma, these infiltrate the optic nerve, giving rise to occlusion of both. Optic nerve trauma, such as blunt or lacerating trauma, hypercoagulable states. This is where the systemic workup comes up, and Dr. Pukraj will be dealing with this. SLE, antiphospholipid syndrome, thrombotic thrombocytopenic purpura and leukemia, inflammatory such as autoimmune vasculitis, particularly Behçet's disease, orbital inflammatory disease, osteoscleritis, all can cause combined occlusion. We ourselves can cause some combined occlusion when we give a retrobulbar block. Rarely it has been described after pars-plana vitrectomy, but I am not too sure of the mechanism. Here, direct infiltration into the nerve can cause this. Optic nerve melanocytoma, optic disc melanocytoma, when it infiltrates into the nerve, can also cause a combined occlusion. Interferon therapy and isolated superior ophthalmic vein thrombosis are also risk factors. What is the mechanism? As far as vasculitis is concerned, it results in vascular wall necrosis and a thrombus formation, like occluding both the artery and the vein. Direct infiltration of the optic nerve, once again because of occlusion of both, and secondary hypercoagulable state because of thrombus formation. Retrobulbar injection, when we inject directly into the optic nerve, it results in blockage of both. Branch retinal artery occlusion and branch retinal vein occlusion has been described in patients with CMV retinitis and HIV. This is once again because of occlusive vasculitis, a combination of hyperviscosity and decreased fibrinolytic capability in HIV. Clinical signs, when you look at these patients, they do have poor vision. It can vary from 660 to NPL, and they do have a gross relative afferent pupillary defect. When we look at the fundus, we do have the signs of blood and thunder fundus of ischemic CRVO. So if you see here, you will see retinal hemorrhages, dilated central retinal vein, soft exudate, pale disc edema, and macular edema, which are the signs which associated with central retinal vein occlusion. In addition, we may find a cherry red spot, and attenuated retinal vessels, and retinal whitening, which are the signs of the central retinal artery occlusion. So both combined together is what you will see in the fundus in association with very poor vision. This is white another patient. You can see gross attenuation of the retinal vessels and the disc edema as well. So this is a patient with a combined branch retinal artery occlusion and a vein occlusion. Only the inferior part is involved here. And when the patient presents to us, the severity can be varying. So it can be very, very misleading. It may appear like this. Some of the central retinal artery occlusion signs are gone. But this is about 3 to 4 months later. See that all the vessels are sclerosed and the disc is extremely pale. There is a patient with optic disc melanocytoma which has infiltrated into the nerve, which has given rise to both a combination of CRAO and CRVO. So investigations, when we do a fundus fluorescent angiogram, there will be a delayed or absent filling of the central retinal artery, dilated vein and delayed or absent filling because of there is no blood flow into the central retinal artery. But we need to investigate these patients much more in contrast to a patient with CRVO. Infiltrative disease, we need to do an MRI of the brain and orbits to see if there is an infective or an inflammatory or a malignant infiltrative disease, a lumbar puncture in patients with meningeal carcinomatosis, and we need to search for primary if there is no history of primary malignancy. Hypercoagulable states, we need to do a hematological workup. Treatment, role of paracentesis, there is a limited role, but then there is no harm in trying because there is definitely a combination of a central retinal artery occlusion in these patients. But if it is because of hematological factors, it may work. But if it is due to an infiltrative, infective, or traumatic cause, the paracentesis will not work because the problem is at the optic nerve head, and this is because of infiltration. Just by doing a paracentesis, there is not going to be increased flow into the retinal artery. As I mentioned, it may be of use in hypercoagulable states. In inflammatory, as in Behçet's disease or a Church-Strauss syndrome, we can give intravenous steroids in addition to anticoagulants. Hypercoagulable states, of course, anticoagulants and fibrinolytic therapy can be tried. Fibrinolytic therapy is infusion of urokinase, 300,000 units over 40 minutes, and if you were to treat this patient within 72 hours, they have shown very good results. Infective antifungal treatment. As I mentioned, Mucor, in particularly diabetic patients, orbital cellulitis is one of the reasons for this combined occlusion. We can institute a systemic antifungal treatment. We can give IV antifungals, and there are papers on retrobulbar antifungals. We have tried it in about 2 or 3 patients, but they are extremely sick patients. So despite all our treatment, they will not do well. Of course, if the patient has AIDS, we need to treat them with anti-HIV treatment. Infiltrative, as in the cause of a malignancy which is infiltrating the optic nerve, we can give systemic steroids to decrease the associated inflammation, but orbital radiation plays a big role because the tumor has to be treated with the radiation. So this is the patient whom we saw earlier. This is about 2 months later. We can see the sclerosis of the arterioles. And these patients can develop fibrovascular proliferation. Dr. Shroff did mention about 20% of the CRAO patients developing neovascular glaucoma or neovascular iris neovascularization. These patients have a combination of both, ischemia because of CRAO and because of CRVO. So they have a higher tendency to develop proliferative disease such as this. So how do we treat the patients who have developed a proliferative disease? Anti-VEGF agents or IVTA does play a role to control the neovascular disease, but visual recovery is likely to be poor because of the retinal arterial ischemia. And macular edema can regress, so some improvement in vision can happen. So to decrease the risk of neovascular glaucoma or iris neovascularization, we can treat these patients with pan-retinal photocoagulation cryopexy. And as I mentioned, nearly about 81% of these patients can go in for rubeosis. So our threshold to treat should be rather low. So at any sign, or if you think this patient is going in for a proliferative disease, better to treat them with a pan-retinal photocoagulation. People have tried radial optic neurotomy in ciliary artery occlusion with CRVO with guarded results, and the complications can be much more than the benefits. So I wouldn't advise this. Prognosis, vision recovery depends on the etiology. If it's a young patient and there's no systemic disease, some amount of vision can be regained. But if there's serious systemic disease in older patient, often vision is not restored. And again, depends on the severity of the occlusion. CRVO, ciliary artery occlusion, has a very good prognosis. BRVO, BRAO, reasonable prognosis, at least half the field they may see. CRVO, CRAO have a very poor prognosis. With fibrinolytic therapy, 7 out of 11 patients improved vision in one of the studies which are published. But this fibrinolytic therapy has to be done in conjunction with your physician if he is capable of doing it. Mucormycosis in diabetics, as I mentioned, these patients are extremely sick. The other eye can get involved in a matter of days and it's life-threatening. So we may be like kind of life-saving treatment if we institute prompt antifungal treatment. We may not be able to save the eye. Thank you very much.